So let us start. One more important topic for exam, rehabilitation in paraplegia. So there are two types of paraplegia. The first is complete paraplegia where there is no movement of the limbs below the level of injury. So if it is dorsal, then there is no movement of the lower limbs. Any cervical, that means no movement of the upper limbs and the lower limbs based on the dermatomes. Incomplete paraplegia is where there is some movement or sensory that is preserved, divided into four types: Brown-Sequard syndrome, central cord syndrome, anterior cord, posterior cord. All of this which you can find. So today we are going to focus on rehabilitation only. So before rehabilitation, there is classification of spinal cord injury. So spinal cord injuries are classified into five types as per Asia classification. Full form is very important. Full form is American Spinal Injury Association Scale, ASIA. So Asia A, B, C, D, E. Asia A is complete. There is no sensation or motor involvement. B is sensory incomplete. That means there is some sensations that are preserved. C is motor incomplete, which means that there is power which is less than 3 in the region below the level. D is motor incomplete, where there is power which is in 3 or more than 3. And E is normal neurology. So when a patient comes to you and you decide what kind of rehabilitation you do with the patient, there are a few questions that the patient will always ask. Is will he or she ever walk? The next question is what are the chances of recovery? And what is going to be his or her life ahead? So based on the type of spinal cord injury, the prognosis is divided as this. So a patient with complete injury, so there are no chances of the patient being able to walk. So it is about 0 to 5%. So examination of such patients becomes very important when we want to classify them as complete or an incomplete patient. So for example, if you classify somebody as B but the patient is A, then you can see that the prognosis changes. So somebody who has power more than 3. So in our wards, in our everyday OPD, we always see that is the patient power more than 3. So those patients have very good prognosis because then motor recovery is up to 80%, sensory recovery is up to 90%, and 80% of them are able to work. Similarly, B and C, when the patient has only sensory, then the chances of motor improvement are very less. But even some preserved power, then there are very high chances that the patient's neurology will improve. So now what are goals of rehabilitation? The first and the most important is improve function, which will help in and improve the motion of the patient, increase the strength, and also improve the comfort. Next is managing secondary complications like bed sores, autonomic dysfunction, orthostatic hypotension, bladder wall functions, and heterotrophic ossification. Then it is promoting independence, support emotional and psychological well-being, and community integration. So all of these are the goals of rehabilitation, not just physical. It has to be physical, mental, psychological, emotional, making the patient independent, and avoid any complication that are a part of their paraplegia or their deficits. So the rehabilitation is divided into three phases. The first is acute phase, the subacute phase, and the chronic phase. So the acute phase is after the injury up to 4 weeks, that is 1 month. Subacute is from 1 to 3 months, and chronic phase is after 3 months. So each phase has a different type of rehabilitation and different way that a patient has to be rehabilitated. In acute phase, first is stabilizing the spine, pain management in terms of analgesics, respiratory care. So patient with cervical spine injury have very high chances of deficit, death within the first 4 weeks. So respiratory care is very important in the first 4 weeks. Regular spinal cord injury assessment, which will help us in knowing the prognosis of the patient, and family education about them. Subacute phase, which is from 1 to 3 months. So at that time, the patient has already been stabilized. And the family knows that this is the situation. So what next? Then comes physical therapy, occupational therapy, sitting, standing, bladder and bowel movement, and psychological support. So why bowel and bladder movement not at that time, and why psychological support after 1 month only? So once the patient is stabilized, a lot of the patients recover in bladder bowel functions. There is some level of knowledge that you have that how the patient's bladder and bowel will behave. And the patient has also started accepting that he is paraplegic. So that is why psychological support plays an important role. So physical, occupational, psychological, bladder bowel, sitting, standing, all of these are a part of subacute phase. The last is chronic phase. So this is which goes on for the life. That is progressive rehabilitation, vocational rehabilitation, family support, recreational rehab, pregnancy and special care for females with deficits. So will discuss this in all these parts: physical rehabilitation, pain, bowel bladder, spasticity, sexual rehab, psychosocial rehab, and occupational therapy. So let's start with physical therapy. So we all know these are the myotomes. So based on where the injury is, we need to decide what muscles are being activated, and based on that, we'll know what kind of physiotherapy needs to be done. So for cervical lesion, if the lesion is between C1 to 3, patient will have difficulty in breathing and will ventilatory support. C4, that means patient will have respiratory movement and the patient can use mouth grip to support. Patient will need a high back chair because there is no neck support. So and will need belts. C5, there is some bicep function. So specialized chair can be there. Patient is eating is dependent. C5 is that there is some hand grip that is present. So the patient can eat by his own, but will need a knob for the wheelchair. C7, 8, so any injury at or below C7 or 8, that means that finger flexures are functional and upper limb activity is independent. So it becomes very important for everybody to remember the dermatomes and what kind of function each nerve root is doing. So C5 is bicep, C6 is tricep, C7 8 is small finger. So under C7 and 8, your upper limbs are normal. Anything above C7 and 8, that means there is some hand function that is affected. And above C3, always remember that no upper limb or no lower limb movement is present. Now coming to thoracic injuries. So we all know that thoracic injuries, so all thoracic nerve roots are sensory and motor function is relatively limited to the thoracic spine. So any level above T6, that means the upper body is functional and there is complete lack of body balance because the paraspinal muscles are also not active. Below D6, there is some movement of the lower body because of the quadratus lumborum, which is supplied level below the T6. T7 and below, the patient can ambulate and exercise. And at T10, 11, they can be ambulating at home also. At lumbar levels, again, the L1 to so long leg devices are needed because the proximal muscle weakness is there. 3, 4, we need to lock the knees because extension can be weak. There is foot drop can be there. And at 4 and 5, the patients are generally independent walkers with only a foot drop splint. So now rehabilitation includes stretching, aerobic exercises, gait training, use of assisted devices, balance and coordination, posture, and therapeutic exercises. So stretching is stretching of all muscles. So all muscles that do not have strength, that are paraplegic, need active stretching, and those muscles that have strength needs passive stretching. In bed mobilization, that is patient needs to sit up by themselves. So this is how you can tell the patient to sit up whose both legs are not moving. First tell them to turn. That's how they can get up and sit. So this is sitting up, then standing. So it can be passive or active. So passive standing is when the patient is just standing without any support. So you tie them and it's called tilt table. So this is very important because it will there will be pooling of blood. So if somebody stands up, will have dizziness if they are not controlled. So tilt table, this is passive standing where they are standing with braces, which improves the musculoskeletal circulation, breathing, bowel bladder function. and this is the initial thing to walk. So if the patient stand, then they can walk. So for example, this is active standing, and this is parallel bar walking, which comes in only after the patient starts to stand. So how they start walking, balance is important. There is gait training, strengthening, and learning to walk with prosthesis. So this is all important about parallel bar walking. So after standing and parallel bar walking, that comes independent walking. And this is when what becomes important is the kind of braces that you can use. So if the pelvis can balance, that can walk with orthosis outside the parallel bar. If quadratus femoris is present, then walking with elbow crutches and without the wheelchair is possible. And between C8 to T1, walking will always need a hip support. So here you can see this guy is walking with a hip support that is holding his trunk, and then he's walking with the help of his hands. So since they are flaccid legs, you need to protect them and hold them for them to walk. So it's called a hip, knee, ankle, foot orthosis for injury above D12. This is a hip, knee, ankle, foot orthosis. This is a kid with hip, knee orthosis. We can see him walking. He's just moving his entire body and is able to walk with that hip, knee, ankle, foot orthosis. Then is knee, ankle, foot orthosis for level around L1 and L2, where there is the hips are functional, but the knee and the quadriceps are not functional. So this is knee, ankle, foot orthosis, and there has been development like a thermoplastic that helps in making a KFO. So you can see this person, this is walking with, he's able to move his hips, and then he's putting a thrust with his hips so he can walk with a knee, ankle, foot orthosis. Next are ankle foot orthosis. So when the knee is functional, but the patient is only not able to walk because of that. So this is ankle foot orthosis. So ankle foot orthosis, the patient should be able to lock his knees. So he can stand. And now with AI and everything, gait control and exoskeletal orthosis are possible where it is all motorized and can able to walk safely, conserve energy, and it's all electricity that is holding. Another important function is transfer training. So transfer training means from moving from a wheelchair to the bed and bed to the wheelchair. This is very important as far as independence is concerned. So when somebody is on a wheelchair and we need to tell him about transferring, so if he is alone, that patient needs to be able to transfer from the wheelchair to the bed and then from the bed to the wheelchair. So we can see here that this she is teaching how to transfer from a wheelchair to the bed. So you have something that's when you sit, that's to transfer to the wheelchair. So without anybody's support, she is able to move from the wheelchair to the bed. This is called transfer training. So the most important part is to design of the wheelchair. We see there is no extra support here. So this is how they can transfer. So transfer training is important. So this is about movement and physiotherapy. So what was there was passive active movement, making him stand, that is active and passive standing. Once they stand, they have to walk, that is parallel bar movement. Once they walk, they need to walk independently. So there are various braces available that will help them walk independently. And for everybody who is wheelchair bound, movement means transfer training where they can transfer from the bed to the wheelchair and wheelchair to the bed. Next comes spasticity. The spasticity is a double-edged sword. Why so? Because spasticity helps in standing because the legs are not flaccid. It helps in gripping and avoid muscle wasting. But on the same side, there is pain, there is difficulty in walking, difficulty to control movement. There are out of control movement that keeps on happening, difficulty to clean, and the skin breaks, etc. So spasticity can be managed by stretches, medications like baclofen, dantrolene, tizanidine, TENS, Botox, and intrathecal baclofen pumps. There are surgical options also available, like selective dorsal rhizotomy, where you cut the dorsal root ganglion, so the nerve supply that is going to the muscles goes away, the motor supply, which is acting as a imbalance, and that's why we do a dorsal root ganglion rhizotomy, and so the imbalance goes on. Next important thing is bowel bladder movement. So bowel bladder training is very important. So there are two types of bladders: the upper motor neuron bladder, that is UNM bladder, and the LMN bladder. So always remember that this is very important question in exam, viva, everywhere. So UNM is what? So UNM means spasticity and LMN means flaccidity. So a UNM bladder will have a diffuser hyperreflexia, that is spasticity. And so that is urgency, frequency, and incontinence. LMN is flaccidity. So there is bladder is atonic. So there is a lot of urinary retention and overflow incontinence. So other are UNM bowel, that is tight sphincters and constipation, and UNM LMN bowel, that is loss of sphincter tone. The two main kinds of bladder. There are other types of bladder as well. So what do we tell the patient? The first is self-intermittent catheterization. Next is putting an indwelling catheter, bladder training by pelvic floor exercises, bowel training, that is you tell them to eat at a fixed time and they know that the stool will be formed and they will go to the bathroom at a fixed time. So that is by avoiding unplanned bowel functions, and digital rectal examination by which they can do a reflex passing of stool. There are medical and surgical interventions also available that can be done. So after this, a very important part that we come to is pain management. So patients which have pain will have neuropathic pain, musculoskeletal pain due to the trauma, and visceral pain. So we can give oral medications. There can be acupuncture or acupressure that can go along with it. There are surgical options that are also available. Putting intrathecal pumps are also available. So all these are options that we have. Sexual rehabilitation, this is again an important viva question. So very important part, and it's often missed and depend on the level of the cord. So any level above T10, there is only reflex erection or arousal. Below T10, so L3 to S1, there is psychological and reflex arousal is present. And below S1, S2, S3, there is the last level, there is no reflex arousal and psychological arousal. So this, at any injury above T6, there are very high chances of autonomic dysregulation. So ejaculation will trigger the vagal tone and thereby causing hypertension and autonomic dysregulation. So they have to be very careful. So for any injury below T12, psychological arousal is possible through visual, auditory, or imagination stimuli. And T11 to T3 injury, L3 injury will cause a retrograde ejaculation. So pelvic floor strengthening exercise and rehabilitation with the help of devices become an important factor. Pharmacology is important for sexual rehabilitation. Autonomic dysregulation, which is a life-threatening situation, and any injury above T6, so ejaculation can be a trigger of autonomic dysregulation. And pregnancy in spinal cord injury is possible. So all of these need to be explained. And the last is psychosocial rehabilitation, where depression, PTSD, suicide attempts are very common. Occupational therapy, so there are pictures, music, crafts, various kinds of occupational therapy that can be there. In Ahmedabad, all this happens at the Spinal Cord Rehabilitation Center. So this is everything that we discussed about rehabilitation in a patient with paraplegia. So when somebody asks you, all these things have to be covered. So to summarize, multidisciplinary approach, important to be aware. We need to be the guide. We need to be the leader who guides the entire team. Mobilization, the various braces available, we should know all of them. It is not only physical rehabilitation, it is part of psychosocial, sexual, occupational, and all kinds of a comprehensive therapy. So that's it. Any questions?
No, sir.
Ama